Good morning, good afternoon. Thank you very much for joining us today for this very interesting webinar and results that I think will be very useful and interesting to the audience. I want to introduce myself. I'm Paul Hewitt. I work at the Population Council under the Breakthrough Research Project, where I'm the technical director of the project. The webinar presented today brings together two of USAID's flagship projects for SBC, Breakthrough Action, that focuses on program and implementation of SBC programming, and Breakthrough Research, that focuses on the research and evaluation to inform Breakthrough Action programming and the global portfolio of research for SBC. And we want to thank USAID Nigeria in particular for their contributions to these portfolios, both in terms of their support, but also in terms of their programmatic and research advice and guidance to make this as relevant for the Nigerian population as possible. So I want to talk a little bit about the work that's being presented. This is a part of a broad portfolio of mixed methods research conducted by Breakthrough Research in Nigeria in 3 northern states, Sokoto, Kebbi, and Zamfara. The work here is based on a quantitative behavioral surveillance survey that will have 3 annual interviews at baseline, midline, and endline, targeting women of within 1,000 days of the window of opportunity. And the reason for targeting these women for the survey is because this is a target group for breakthrough action implementation to improve both ideational factors that influence behaviors, but also the behaviors themselves. Both projects are very keen on moving metrics in maternal and child health, nutrition, malaria, as well as family planning. The baseline behavioral surveillance survey data that is being presented today was collected in September of 2019, and the results of this are being disseminated throughout a series of webinars and briefs and research products, including a report that are available at our Breakthrough Research and Breakthrough Action website, and we'll put links to those in the chat box. You can also see previous webinars on other topics presented today, presented previously, as well as the availability of the briefs and other technical documents that supplement what is being presented today and provide a bit more detail, including a webinar that is focused on the research methods that are underlying or the foundation of the work today. So the webinar today will present the results and findings looking at the psychosocial influences on sick child care for cough, diarrhea, and malaria. And it'll look at the relationship between the determinants or the ideational factors that influence behaviors in these domains for the target audience of women within 1,000 days, and look at how those have the findings and results of the survey inform breakthrough action programming. We have some very good presenters today. We have Dele Abengunde, who's the Chief of Party for Breakthrough Research. We have Shitu Abdu Aguye, who is the Deputy Chief of Party for Breakthrough Action on the implementation side. And we also have Emily White Johansson, who is the Deputy Chief of Party for Breakthrough Research and is the technical lead in doing a lot of these analyses that is presented today. Behind the scenes is also Paul Hutchinson at Tulane University. He's a health economist and also the PI on the work that's being presented. Well, I would like to turn it over to Dele for quick introductions and really appreciate the fact that everyone's joined. And please do, if you have any questions as we go along, put them in the chat box because we'll answer them in real time. And then hopefully we'll reserve a little at the end for questions and answers that remain unresolved. So handing it over to you, Dele.
Thank you very much, Paul. It's always a pleasure to work with you on this project. Next slide, please. I think Paul has done a good job in introducing the topic. Next slide. Just to give you an overview of our discussion today, I will be talking briefly about what breakthrough research is, and I'll be introducing what the behavioral sentinel surveillance survey is. I will also talk a little bit on the focus. The focus of today's presentation is really on care seeking and treatment for the sick children. Like Paul said, we have had a series of webinars and we're still going to have a little bit more series even after today. So you're always welcome to join us to discuss and interrogate these findings in a robust manner. Also, we will be listening to how this formative research inform BSS survey, and then we'll be talking about new additional metrics that will be displayed in the results, and then the key findings will also be discussed, and the program implications of the results of this finding. Finally, we will talk about the future work that will still go on after the implications of today's presentation. Next slide, please. Like Paul introduced, Breakthrough Research is the USAID's flagship project for social and behavioral change, research and evaluation in Nigeria. It's a 5-year project, Breakthrough Research generally. That started in August 2017 to end in July 2022. The Nigerian activity started in 2019, and then the office was established in September 2019. Breakthrough Research is in close collaboration with its sister project, the Breakthrough Action, and other PIs. We are presenting today with Breakthrough Action in our collaborative work. I think, next slide. I will hand over to Shitu Abdullahi to give us a background on breakthrough research in Nigeria. Shitu, thanks.
Thank you, Dele, and thank you, Paul, for the introduction. Good morning, good afternoon, everyone, wherever you may be joining this presentation from. I'll use the next few slides to introduce Breakthrough Action Nigeria. Breakthrough Action is USAID's flagship global SBC project with a presence in over 29 countries. Breakthrough Action and Breakthrough Research were jointly awarded by USAID and have similar timelines, with both projects running from 2017 to 2022. The goal of the Breakthrough Action Nigeria project is to increase the practice of 17 priority health behaviors which cut across MNCH, family planning, and malaria. Intermediate results include improved individual and social determinants of health, this by implementing SBC interventions targeted at knowledge, attitudes, and social normative barriers, including gender, strengthened coordination and collaboration with USG partners on SBC interventions. Our primary partners are Breakthrough Research, the Integrated Health Project, IHP, and the Global Health Supply Chain Procurement and Supply Management Project, GHSC-PSM. And finally, strengthen capacity for SBC coordination and implementation among government partners at federal and state level. Next slide. With 17 priority behaviors to address through integrated programming, Breakthrough Action Nigeria grouped the behaviors by milestones and life stages to enable implementation of systematic and coherent SBC interventions. The milestones run through the pre-pregnancy period, when using a modern contraceptive to space childbirth is a key behavior, to the period when children are 2 to 5 years old, where seeking prompt and appropriate care for childhood illnesses is a critical behavior for reducing child morbidity and mortality. Breakthrough Action Nigeria also has further clustered priority behaviors and life stages to guide audience segmentation for community level activities. Next slide. So Breakthrough Action Nigeria uses 5 coordinated multi-channel approaches for the project's SBC interventions. Community mobilization is at the core of all BA-SBC interventions and has 2 major components: community social behavior change, or what we call community SBC, BA's direct demand creation activities, which include house-to-house visits, community health dialogues, and compound meetings conducted by community volunteers. It is from these activities that committee members are issued referrals to access FP, MNCH, and nutrition services at health facilities. With community capacity and sustainability activities, BA supports community structures like WDCs, World Development Committees, to take ownership of problem identification and problem solving on FP, MNCH, and nutrition challenges in their communities. The WDCs are supported to develop community health action resource plans, or what we call the CHAP, that guide planning and resource mobilization for interventions proposed by the communities themselves to improve the practice of priority MNCH and nutrition and behaviors. Mass media is where BA has the popular Albishirinku radio drama that airs on multiple radio stations in Bauchi, Sokoto, and Kebbi, and now also in FCT. The radio drama is designed for edutainment and follows the story of Jamila and Farouk as they navigate health and social issues related to pregnancy, childbirth, and caring for their newborn infant. The drama has a unique format with 5-minute segments involving different characters and influencers aired multiple times daily, with the full 25 minutes aired at the weekend. Breakthrough Action also supports development and airing of radio spots, magazine programs that complements the Albishirinku drama as well. Breakthrough Action's mobile digital interventions are cross-cutting and support all other program approaches. Through a collaboration with Airtel, Breakthrough Action's mass media content, including the Albishirinku radio drama and centerpiece spots, can be accessed free on the Airtel 321 platform. Other specific mobile digital interventions are mobile data collection for community activities, deployment of IVR mobile curricula for training community volunteers, and mobile referrals. Breakthrough Action also works with influential religious, traditional, and opinion leaders through the social behavior change advocacy core groups, SBC-ACGs, to address social and gender norms related to the practice of priority health behaviors. Finally, through the provider behavior change approach, BA Nigeria works with health service providers to improve adherence to national malaria prevention and treatment guidelines and improve respectful maternal care. Next slide. Breakthrough Action Nigeria works in 11 states across Nigeria and FCT. The integrated approach, SBC approach, is implemented in 5 states, and other states have vertical SBC interventions. Breakthrough Research's behavioral sentinel surveillance study is being implemented in 2 of the integrated states, Sokoto and Kebbi, and 1 vertical SBC malaria-only state, which is Zamfara State. So I'll stop here and hand over back to Dele or Emily to continue with the presentation.
Thank you. So thank you, Dele, Paul, and Chitu. I'm Emily White Johansson, the Deputy Project Director at Breakthrough Research Nigeria and Director of Research and Evaluation there. I'm going to talk now about the Behavioral Sentinel Surveillance Survey, or BSS as we call it, both in general and also in terms of our specific research results related to care seeking and treatment for children with illness symptoms. So the main objective of the BSS is to assess the effectiveness of integrated versus malaria-only social behavior change programming on malaria, family planning, and maternal, newborn, and child health plus nutrition outcomes This is among pregnant women and women with a child under 2 years living in the program areas within the 3 states in northwestern Nigeria. The BSS measures priority behavioral outcomes across each of these health areas that's standardized with what's collected in a DHS. But importantly, and in addition, we also collect metrics on psychosocial influences, or ideations as we call it, across cognitive, emotional, and social domains that are theorized as intermediate determinants of behavioral actions and decision making. So the psychosocial factors that were developed for this survey are based on the Kincaid theory of strategic communication and behavior change. And this theory posits a pathway from exposure to communication activities, all of the activities that Shiti described in the previous slide that they do, mass media, advocacy, and community activities of BA programming. And these communication activities are posited as going through 3 ideational domains and influencing 9 ideational subdomains that should then in turn lead to changes in intentions and behaviors. So survey questions were intended to measure as many of these domains as possible across all of the priority health behaviors. So if you figure that we have 17 core behaviors, 9 subdomains, that's a minimum of about 150 questions to get a comprehensive look at the drivers of all priority behaviors. Now, in reality, we had many more questions than that, but it still wasn't even as comprehensive as we would have liked, but we had a trade-off, of course, between being comprehensive and also risking quality of the survey through respondent fatigue. The main study population for the BSS were currently pregnant women and women with a child under 2 years of age. These populations, again, correspond to the main life stages that Chitu described and that are the focus of BA programming. Specifically, they focus on what we call the priority 1,000-day window of opportunity from pregnancy through the first 2 years of life of the newborn. So we collected data in all 3 states, but the data are only representative of BA program areas within the states and not the states themselves. The study design involves both cross-sectional and cohort components to provide estimates of prevalence of behaviors and ideations over time. We will use repeated cross-sections of women with a recent completed pregnancy at 3 time points, the baseline, midline, and endline time points of the BA project, Breakthrough Action Project. We also follow a cohort of women who were pregnant at the time of the baseline survey to document their 1,000-day window experience throughout the project period. There's a quasi-experimental component in the sense that we're comparing geographies with integrated programming, that's Kebbi and Sokoto states, with those with malaria-only vertical programming or SPC programming in Zamfara state. The sample size includes just over 3,000 women who were pregnant at the time of the survey and another 3,000 women with a recent pregnancy based on a randomly selected sample. And in the presentation today, we present both bivariate and multivariate analysis. And for the multivariate analysis, where we will present predicted probabilities of an outcome occurring that's derived from mixed effects logistic regression models adjusted for socio-demographic variables such as wealth, age, education of both the respondent and spouse, and employment of both the respondent and spouse. And just to say that the final baseline technical report is now publicly available. It's on our website at the link listed here. That's also along with all of the previous webinar and research briefs across different health areas. This full report includes a full description of the survey methods as well as a complete descriptive results with over 500 indicators reported by state. And I really encourage everyone to download the report and get a sense really of the breadth and the richness of the data that we've collected, not only for child health, but also for maternal health, family planning, and other areas too. So just to talk quickly about the formative research that informed this survey. So Breakthrough Action, our sister project, has conducted wide-ranging formative work during its first year on the ground, and we really drew heavily on this in developing the survey questionnaire. You know, some of their results were from their own literature reviews or qualitative interviews or focus group discussions that they conducted that indicated reasons for care seeking from certain locations, for not care seeking at all, or for giving different treatments to young children who were sick or had illness symptoms. And some of the results that they had were factors associated with not seeking care or maybe poor treatment practices, included such barriers as healthcare costs, facility distance, negative views of health services, low awareness of common pediatric illnesses such as pneumonia, and of course, gender dynamics and sociocultural norms in a northwestern region. And all of this previous research and formative studies that were conducted by BA really helped us to shape the questions and the response categories that were asked in our survey. So we developed new metrics for much of the BSS survey, and there are a lot of ideational metrics in the literature related to knowledge, attitudes, intentions, for family planning and malaria, but there's been much less published work in the area of maternal and child health, specifically for childhood diarrhea or pneumonia that we'll present today, or for other areas like pregnancy and childbirth. And again, as I said before, it's important to have this kind of information because in the theory of strategic communication and behavior change, ideational factors are so important. They're the basis for BA programming and what they target in order to spur action and for investment in SBC programs, both in Nigeria and globally. So it's really important to test the underlying relationships between these ideational factors and the behavioral outcomes according to this theory. For malaria, again, there is published research and from the northwestern Nigerian region by Stella Babalola and others at Johns Hopkins University that we drew heavily on for this survey. But there was much less available for diarrhea and pneumonia ideational metrics that we had to develop. And the questionnaire was developed jointly with BA and with input from outside child health experts. And again, as I mentioned before, we had to ask a limited set of ideational questions across each health area, or we would have just had a very long questionnaire. So questions were prioritized based on their importance programmatically. So this next series of slides just shows the ideational questions that we asked. So here are the ones for malaria. And again, for each health area, we try to ask at least one question for each of the specific ideational domains. So for example, for knowledge, we asked, what do you think causes malaria? And then we coded the data for analysis as those that provided correct answers, as those who did not. For beliefs, we included statements such as, even if the malaria test is negative, I always worry it may still be malaria, or a health provider is the best person to talk to when a child is sick. And we coded responses as strongly agreeing with the statement, somewhat agree, somewhat disagree, strongly disagree, or don't know. And we also included questions related to emotional and social domains, including self-efficacy and social influences on decision making. And we use the same structure for developing the diarrhea ideational metrics, but for this health area, there was limited previous research. There was some in Zambia that had been conducted that we adapted to the Nigerian context and then also developed some of our own. So for example, for knowledge, we asked, in your opinion, how does ORS help a child with diarrhea? For beliefs, we included statements such as, in young children, diarrhea can lead to dehydration or even death. And then again, coded responses as agreeing or not with that statement. For pneumonia, again, it was the same structure, and we really did try to harmonize across this area of pneumonia, diarrhea, and fever, malaria. But in this case, actually for pneumonia, there was no previous research on which to draw. And again, trying to harmonize with what was done with diarrhea, we asked what medicines are effective in treating a child with pneumonia. For beliefs, we asked, young children can get severely ill from pneumonia. They could be hospitalized or even die. And I should also mention that we published a pneumonia-specific ideational analysis earlier this year in a special issue of Pediatric Pulmonology that focused on pediatric pneumonia in Nigeria. This article within the special journal issue was launched at the Global Forum for Childhood Pneumonia in January of this year, when Nigeria actually launched its National Pneumonia Action Plan. and Udo Chisholm Anaba on our team led this work. So if you're interested in this specific area, you can also go read this article and see details of the ideational metrics and the relationship of these ideations with care seeking and treatment for children with symptoms of pneumonia. So now we get to the findings, the part that we've all been waiting for, and I'll present the key findings according to the SBC program priorities, including behavioral patterns. So how frequently at this baseline period do respondents practice the promoted health behavior? What are the key behavioral patterns by geography or socio-demographic characteristics? In terms of knowledge and beliefs, are respondents aware of the promoted behavior, such as how to prevent the disease? Are certain beliefs held by respondents that could impede progress? Barriers, how do respondents view health services in their communities? What are the main reasons for choosing certain treatment locations or for not using services at all? Social influence and decision making, how do health decisions get made in households and who mainly influences women's healthcare practices? And then finally, at the end, we look at the ideational relationship. So we then conduct multivariate regression analysis to look at the relative importance of all, knowledge, beliefs, barriers, social influences on these behavioral outcomes. So we can ask the questions, how important are the individual components of behavioral change frameworks? What ideation should SBC programs target to maximize impact? So in terms of behavioral problems, you'll see from this slide that across the study area, there was very low care seeking and treatment rates for children with symptoms of diarrhea, cough with fast or difficult breathing, and fever. Only 21% of children with diarrhea were given ORS and zinc treatment. Only 22% of children with fever were tested for malaria. And I should also say in our analysis, we examined care seeking from formal medical sources. And formal medical sources, that definition is standardized with what's reported in the Demographic and Health Survey for Nigeria to include government hospital, PHC, health post, community health outreach post, and private hospital clinic. So when you see that in down the road in this presentation, you'll know what's included there. So in this series of slides, you'll also see that there was low, but also very inequitable coverage, even within these very poor states in the Northwest region. So for diarrhea, there was much higher treatment rates with ORS and zinc among children living in the richest households compared to the poorest. And for fever, it was similar, with a greater proportion of children under 2 years with fever living in the richest households who were tested for malaria than those in the poorest households. In terms of knowledge, we found really high general knowledge about malaria, but in contrast, really quite low awareness about pneumonia and diarrhea. So while nearly all respondents reported or responded they knew that mosquitoes bites cause malaria or sleeping under nets helps to prevent malaria, 43% had never heard of or didn't know how zinc helps for diarrhea. Only 31% knew antibiotics were a treatment for pneumonia or against pneumonia. And only 28% knew rapid or difficult breathing is a sign of pneumonia in children. There were also strong doubts about malaria testing across the study area. So when respondents were given the following statement, even if the blood test is negative, I always worry it may still be malaria. 61% agreed with the statement, and in fact, 1/3 strongly agreed with the statement, indicating a firmly held perception about malaria test accuracy or potentially inaccuracy. And in terms of barriers, we asked women who did not seek any care for their child who had an illness symptom in the previous 2 weeks, separately for each of the illness symptoms, about reasons why they did not seek care. And the most commonly cited reason was too expensive. Almost 1/3 of women cited healthcare costs as a reason for not seeking any care for their sick child. And importantly, this top reason is actually different from health areas, particularly the uptake of maternal health services, antenatal care, and giving birth in a facility. where spousal opposition was by far the most common reason cited, and that's much less commonly cited for seeking care for sick children. Other commonly cited reasons by women who did not seek care was fatalism, it's up to God, and also that the symptoms were not severe and that they could provide home care. Among the women who did seek care for the sick child, we asked them about the reasons for choosing different treatment locations. So provider trust, nearby location, and the perceived effectiveness of treatments received at the location were common reasons for choosing treatment location. Among women who attended pharmacies, they responded short wait time, nearby location, friend, family recommendation, and low cost. And those were cited more commonly compared to women who attended government hospitals or PHCs. And in contrast, women who attended government hospitals or PHCs, they more often cited provider trust, effective treatment or perceived effectiveness of treatments received at that location, and respectful care. And those were more commonly cited compared to women that attended pharmacies. In terms of social influences, when we asked women who besides themselves may influence their decision to seek care for a sick child, the vast majority of women reported their spouse or husband. However, as we'll see in the next series of slides, spousal influence was not significantly associated with any of the outcomes for any of the illness symptoms. And again, that is in contrast to other health areas, specifically maternal health services, antenatal care, giving birth in facility, where spousal support or spousal influence was significantly associated with uptake of those services. So now we get to the point where we look at the ideational relationship. So we look at the knowledge, beliefs, social influences, and we put them in a multivariate regression model to see the relative importance of these different psychosocial influences on care seeking and treatment for sick children. And from multivariate analysis, we see that positive perceptions of health services matter for seeking care from formal medical sources. Women who believed a health provider is the best person to talk to for a sick child were about twice as likely to take a child with diarrhea or fever to formal medical care. Women who believed health facilities often have medicines needed for sick children were 1.9 and 1.3 times more likely to take a child with cough and faster difficult breathing symptoms or fever, again, to formal medical care. But the health services perceptions don't just affect care seeking to formal medical sources, but also diagnosis and appropriate treatment practices. We see that women who believed a health provider is the best person to talk to for a sick child were 2.5 times more likely to give ORS and zinc for diarrhea. Women who cited health providers as influencing decisions to seek care for a sick child were 3 times as likely to also give ORS and zinc treatment. Women who believed health facilities often have medicines for sick children were 1.6 times as likely to have a child with fever tested for malaria. But just as a word of caution in interpreting these results, I should also note that there may be some reverse causation here, such that women who had a child tested for malaria, for example, must have visited a facility with tests in stock, and so she will answer positively about her healthcare experience likely, and that facilities have items in stock. So the experience here maybe shaped her perception, but in turn it may also influence future care seeking. When we looked at multivariate regression analysis on pneumonia and diarrhea outcomes, we see that knowledge is critical for formal care seeking and treatment for these illness symptoms. And as we saw in the previous slide, there is very high malaria knowledge, but low knowledge for pneumonia and diarrhea. And so in regression analysis, we see that women who knew how to prepare ORS and know that or reported that ORS and zinc are effective treatments for diarrhea were 2.2 and 6.2 times as likely to give ORS and zinc treatment for a child with diarrhea, respectively. Women who knew antibiotics were a treatment against pneumonia were 1.4 and 1.3 times as likely to seek formal medical care and to give antibiotics for symptoms of cough and fast or difficult breathing. Pneumonia beliefs may also hold back progress. Women who believed young children can get severely ill with pneumonia were 1.7 times as likely to seek formal medical care for these respiratory symptoms. Women who believed only weak children die from pneumonia were significantly less likely to give antibiotics for symptoms of cough and fast or difficult breathing. And also from regression analysis for having a child with fever tested for malaria, we also see the importance of malaria beliefs and women's self-efficacy in terms of her confidence in convincing her husband to seek care for a sick child. So women who felt confident they could convince their husband to seek care for a sick child were 3.6 times as likely to have the child with fever tested for malaria. Women who believed blood tests were the only way to know if a person has malaria were 2.4 times more likely to, again, have the child tested for malaria. So now I will turn the presentation back to Shitu, who will discuss the program implications of these findings and how Breakthrough Action will use these results for further program learning and adaptation. Thank you.
All right, thank you, Emily. So the presentations we've just gone through has shown there's low formal care seeking, diagnosis and treatment for sick children. Only between 1/5 and 1/3 of children receive care from a formal medical source or get some appropriate interventions for their symptoms. Therefore, perceived and actual quality of health services need to be addressed to improve formal care seeking by caregivers of these children. So BA currently refers clients to the formal health services, and will continue to promote the use of these services on the projects. However, actual services at health facilities must improve for improved perceptions about quality to be sustained as we continue to message at community level. And also because short waiting times and nearby location, low cost of services are real incentives that make caregivers access services outside government hospitals or PHCs. SBC program approaches like BA's Provider Behavior Change Initiative can help to ensure that clients get quality care, irrespective of where they access these services. Next slide. We also saw that relative to malaria, knowledge on pneumonia and diarrhea was low. This tells us really that we have our work cut out on improving knowledge and practice of the related priority behaviors to these two conditions. Reinforcing messages on the severity of pneumonia and prompt care seeking for symptoms will be required to improve outcomes in these areas. We've also learned that doubts about the validity of malaria RDT, rapid diagnostic tests, remain a pervasive barrier to its uptake. So while Breakthrough Research explores further research on misperceptions on malaria rapid diagnostic testing and looks at recommends appropriate SBC interventions, BA Nigeria will use the learnings so far to strengthen ongoing SBC interventions using adaptive approaches to improve knowledge, attitudes, and appropriate care seeking behaviors for diarrhea, symptoms of pneumonia, and fever. Thank you.
Thank you very much for your patience in listening. I want to thank Emily and Shitu again for that lucid presentation. What are the next steps after this? Next slide, please. We're conducting we are conducting further BSS analysis, digging down the data to inform SBC program adaptation and scale up, particularly for breakthrough action and other programs in Nigeria that are focusing on SBC. We're preparing manuscripts and research briefs to further disseminate our results. This activity is far advanced now. We are at the stage of planning the next wave of the BSS study, the midline survey. Although there has been understandably some delays due to COVID-19, but we are working in tandem with Breakthrough Action, that is already preparing to continue their programming on the field. We are presenting BSS results by specific health areas in our webinars. We started these webinars in June. Thank you for your attendance today. We still have a couple of webinars, webinar presentation in the next 6 weeks ahead of us. We hope you will join us again to listen, learn from these results, interrogate the results, and then learn how to incorporate them into your various programming. Next slide, please. Our future, like I said, we've had about 6 webinar topics that we have presented. We have the next one will be on malaria. I think everyone should be interested in this because of the importance of malaria globally and in Nigeria, and how it presents cross-cutting kind of factors and determination across health, particularly in children and in pregnant women. Then there will be family planning webinar on the 30th of September, and then an overarching theme, how inequalities in the determinants that we're studying influence the result, and also influence ideation, influence behavior in the areas that we are studying. Next slide, please. Now, for our future work and significance, BSS baseline results are a first step for assessing effectiveness and cost benefits of integrated versus malaria-only SBC programs in Nigeria. It highlights ideation and behaviors during this baseline period to inform SBC program scale-up and adaptation. It presents new additional metrics like you have had today across maternal, newborn, childhood health, and nutrition areas, and quantify their relationship with behavioral outcomes to test behavioral change theories. We'll link BSS results with routine program data or health facility records to examine the impact of supply and demand side factors on service use. Because ultimately, what we're doing was to, what SBC is doing is to modulate ideation and behavior to increase demand for healthcare. So we are going to be linking the supply side and the demand side to see how the supply side is influencing also the demand side. Next slide, please. Now, this is basically our presentation. Today, we want to also appreciate our project team, Paul Hutchinson and Paul Hewitt. Both have been introduced. Paul Hewitt has introduced both today. They are the principal investigator on this team. They are the powerful think tank behind all the work that we are doing. Emily White, also, who you have just listened to, lucidly presenting the results for today's webinar. That's Elizabeth Omoluabi, who works in CRED with Akani Akemi, a professor in Ife, working with CRED, are the people who worked on the field to scientifically obtain the data from respondents. Of course, me, yours sincerely, Dele Abigunde. We have Dominic Mikas and Tulane University, and Udo Chisholm, Anaba. He's been in the background answering your questions. He's the research coordinator on breakthrough research in Nigeria, and then Stella Babalola from Johns Hopkins. We'd like to acknowledge again always the collaboration that we get in BA, led by Ian Tweedy, the country project director for Breakthrough Action Nigeria, and then Matthew Oko in also Breakthrough Action Nigeria. So by and large, this is the presentation on this topic today. We would like to entertain your questions. Sherry Oshinson is also in the background. She's the one that is the captain of today's webinar, putting all things together, who will lead us in answering these questions. As these questions have been displayed, if there are any questions, Emily White, Shitu and Udo and me will be answering. We'll try to answer your questions as best as we can. Before that, again, I want to appreciate Jerry Washington that is putting all of these things together and making it work. I will give it to Paul Hewitt, our technical director, to coordinate the question and answer question. I always appreciate their perspectives to many of the things that we deal with. I think they will be best to coordinate the question and answer session. So before then, I want to thank you all again for attendance. For your attendance, we would like to see you in 2 weeks' time when we'll be dealing with malaria. I think it will be doubly interesting for us to listen to the results from the malaria section. Paul Hewitt, thank you. Over to you now.
Great, thank you, Dele. And a big shout out to our presenters today, Emily and Shitu in particular, did an excellent job guiding us through the presentation. And thank you, Dele, for your chairmanship. Just a few pointers that in the Q&A section of the Zoom chat, you'll find a lot of questions and answers that have already been addressed, but there are a couple I think that are outstanding that we can address in the remaining 4 minutes of the webinar. So Emmanuel asks, beyond provider behavior, is BA able to influence service quality, costs, et cetera, and how does the findings impact on IHP, which is the Integrated Health Project in Nigeria, and PMI for states. And Ranti asks, to dispel wrong perceptions, I believe that program should work with local beliefs to build bridges as this works better for behavior change. Was your study able to get these beliefs about the causes and care for childhood illnesses? And I think in this context, Breakthrough Action is well positioned both with their programming to address these questions and Shitu's expertise on the topic. So I'm going to hand it over to him and his colleagues to address these particular questions. And thank you very much.
All right, thank you, Paul. To respond to Emmanuel's question, Breakthrough Action is completely SBC focused. We do not work in the service delivery or quality or system strengthening space. But definitely these findings are also shared with IHP and PMI for states, other partners who work in those areas around the program areas, malaria, nutrition, and things like that. So I'm sure many of them also attend these webinars, and they will take these learnings and see how they can adapt their programs to address some of the issues that have been identified from this study. But we continue to address the SBC side of things. To respond to Ranti Ekpo, yes, we have actually. I think that's the initial work that Emily referred to that Breakthrough Action did. That formed the basis of some of the further thinking that went into developing the BSS questions. Breakthrough Action conducted HCD formative assessments in Bauchi, Sokoto, and Kebbi at the beginning of our work, where we learned a lot about social, cultural, gender norms related to the priority behaviors that we are working on. And we actually use those learnings really to design and many of our interventions to address some of those cultural, local beliefs, as you put them, to ensure that we're addressing things from the angle that communities and people understand, and we're also remaining cognizant of the norms, the positive norms that we can reinforce, while also addressing those that may be not as positive as we would like them to be on the behaviors that we're trying to change. So yes, we do have that study. We could easily find a way to share that with others if they're interested in seeing more of what we learned around local beliefs, cultures, social and gender norms. Thank you.
Great, thank you.
Can I just...
I'm going to just call on Emily. I hear her voice.
No, just to add to what Chitu said, they're focusing on the demand side of the social behavior change in communities with some provider behavior change, but there are a number of initiatives in the BA program area, including the USAID-funded IHP project that's working on improving health services capacity, the One PHC, One Ward program that I believe UNICEF is also involved in. So there is work in the areas where the social behavior change program is going on. Those are the same wards where USAID is funding IHP to work on improvement in quality in the primary health care, or PhDs.
Great, thank you, Emily. And I see that our time has come to an end. I just want to really thank the audience participation for all those interesting and engaging questions. Just mention, if you have colleagues that weren't able to join the webinar, please feel free to send them the link to this webinar or to the full series of webinars to get out the message that there's a lot of interesting data and programming going on in Nigeria, and hopefully we will hear from you and see from you in the next series of webinars as well. So take care, and thanks everyone for joining.